Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Impact of Bleomycin and Vincristine Dose Reductions in Patients with Advanced Hodgkin Lymphoma Treated with BEACOPP, an analysis of the German Hodgkin Study Group HD12 and HD15 trials by Heinz Haverkamp et al. My name is Allison Moskowitz, and I am an assistant attending at the Memorial Sloan Kettering Cancer Center in New York. My oncologic specialty is lymphoma. Hodgkin lymphoma is highly curable with multi-agent chemotherapy. However, the treatments are associated with well-described toxicities. One of the most serious potential toxicities associated with either ABVD or BEACOPP is bleomycin pulmonary toxicity, which occurs in about 15 to 25% of patients receiving ABVD. Bleomycin pulmonary toxicity is typically associated with dry cough and shortness of breath, although patients can be asymptomatic despite radiologic pulmonary findings. Symptoms can be mild and reversible with corticosteroids, although in some cases pulmonary toxicity can be fatal despite treatment. Patients over 60 are at particularly high risk for pulmonary toxicity, with rates as high as 43% seen with ABVD. In addition, death due to pulmonary toxicity is more common among older patients, which has been reported in 13% of patients 40 and older treated with ABVD. For patients with suspected pulmonary toxicity, it is standard practice to discontinue bleomycin. However, a common concern among patients and physicians is that tumor control may be reduced in these settings. Interestingly, several analyses of patients treated with ABVD indicate that stopping bleomycin early has no effect on Hodgkin lymphoma cure. In a 2004 letter to the editor in Journal of Clinical Oncology, Canellos and colleagues discussed the impact of bleomycin discontinuation for patients with Hodgkin lymphoma treated with at least 6 cycles of ABVD on the randomized trials CALGB 8251 and 8951. Among the 363 patients, 11% required early discontinuation of bleomycin. However, this had no impact on response rate or time to relapse. In a retrospective analysis from the Mayo Clinic of 141 patients treated with bleomycin-containing regimens for Hodgkin lymphoma, in which they primarily received ABVD or MOP/ABVD, 22% of the patients had bleomycin omitted, and this did not affect response, rate of relapse, or overall survival. However, the development of bleomycin pulmonary toxicity did impact survival and was associated with a 5-year survival of 65% compared to 90% for unaffected patients, illustrating the importance of early discontinuation of bleomycin for patients with signs of toxicity. Until now, we had limited data regarding the rate of bleomycin discontinuation for pulmonary toxicity in patients receiving baseline BEACOPP or escalated BEACOPP and its impact on treatment efficacy. Compared to ABVD, one would expect a lower rate of pulmonary toxicity given the lower cumulative dose of bleomycin used and the inclusion of prednisone in the regimen. Distinct from ABVD, BEACOPP also includes vincristine, which is well known for causing neuropathy and constipation, often leading to dose reduction or discontinuation, a problem seen less commonly with vinblastine, the vinca alkaloid included in ABVD. In the article that accompanies this podcast, Haverkamp and colleagues from the German Hodgkin Study Group investigate the impact of bleomycin and vincristine discontinuation for patients receiving BEACOPP. Included in their analysis were patients enrolled on the HD12 and HD15 German Hodgkin Study Group studies for advanced stage Hodgkin lymphoma, in which patients received either 6 to 8 cycles of escalated BEACOPP, 4 cycles of escalated BEACOPP followed by 4 cycles of baseline BEACOPP, or 8 cycles of baseline BEACOPP on an accelerated schedule of every 14 days. They analyzed patients who completed the full number of chemotherapy cycles on study, which included 3,309 of the total 3,700 enrolled. Overall, 17.6% of the patients received an abbreviated number of bleomycin cycles, including 11% who had permanent discontinuation of bleomycin over the course of treatment. Also, 32.6% received fewer vincristine cycles, and 25.9% permanently discontinued vincristine over the course of treatment with BEACOPP. Discontinuation of other drugs within the BEACOPP regimen was rarely seen. To allow for sufficient numbers for analysis, the authors focused their study on the toxicities and outcomes for patients who received fewer than 5 cycles of bleomycin or fewer than 4 cycles of vincristine. With regard to bleomycin, 4.7% received fewer than 5 cycles, mostly due to permanent discontinuation. Not surprisingly, among the patients who received fewer bleomycin cycles, a significantly higher number, 24.8%, experienced grade 3 or 4 respiratory toxicity compared to only 4.7% of the patients who received 5 or more cycles. Despite higher rates of toxicity, after about 5 years of follow-up, there was no significant difference in progression-free survival or overall survival for the patients who received fewer than 5 cycles of bleomycin compared to those who received more. The analysis of patients who received fewer cycles of vincristine showed similar findings. Overall, 6.6% received fewer than 4 cycles of vincristine, and these patients were significantly more likely to experience grade 3 or 4 nervous system toxicity. However, progression-free survival or overall survival was not affected by early vincristine discontinuation. Based upon this analysis from the German Hodgkin Study Group and prior analyses of ABVD, physicians should not hesitate to discontinue bleomycin for patients who develop signs of pulmonary toxicity. Likewise, for patients receiving BEACOPP, early discontinuation of vincristine for patients experiencing moderate toxicity is acceptable. Given the lack of impact on outcomes with early discontinuation of these drugs, one wonders whether either of the drugs are even necessary in treating Hodgkin lymphoma. As Haverkamp and colleagues point out, though, elimination of bleomycin from the ABVD regimen was attempted in the HD13 study for patients with early-stage favorable Hodgkin lymphoma, and tumor control was inferior for the patients who received no bleomycin. We would assume that inclusion of bleomycin would be at least as important for advanced stage patients as it appears to be for favorable early stage patients. Regarding vincristine, its importance as part of the BEACOPP regimen is unknown. Complete elimination of these drugs in Hodgkin lymphoma treatment may become a reality as current studies are evaluating variations on our standard regimens by incorporating brentuximab vedotin in exchange for bleomycin and other agents. In particular, the ongoing Echelon-1 study is comparing ABVD to brentuximab plus AVD, thus omitting bleomycin. In addition, the German Hodgkin Study Group is evaluating modifications of the BEACOPP regimen through their targeted BEACOPP study, in which brentuximab is replacing both bleomycin and vincristine. We look forward to the completion of these studies, which will hopefully bring improved toxicity and even higher efficacy to the frontline treatment of Hodgkin lymphoma. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.